Welcome to the Healthcare Unfiltered Express, where I conduct short video interviews packed with relevant and timely information that you cannot miss. So sit back and enjoy the show. Monty, it's so good to see you. Thank you for joining Healthcare Unfiltered Express. So we're talking today about papillary cell kidney cancer. So I'll start just by asking you a little bit about what it is, and then how do we treat it in early stage, how we treat it in advanced stage.
Yeah, absolutely. It's a great topic because I imagine that these days, I think that a lot of my colleagues in the community are becoming very, very proficient in treating clear cell, which is 80% of all kidney cancer subtypes. And, if you look at it on the microscope, you've got these nice plump cells with abundant cytoplasm. Papillary renal cell carcinoma, as the name implies under the microscope, is very sort of frond-like. It tends to have a very different underlying biology. It's not driven by VHL. Many cases are driven by a gene called MET. So there's huge differences, but certainly it's a bit of a rarity compared to clear cell.
So what's the incidence?
Yeah, so if you think about it, if we have 64,000 cases of kidney cancer per year, it's probably about 15% of that. So you might assume that we see something on the order of maybe 8,000 patients a year with papillary.
So early stage, when patients present with early stage, is it more common to have present early stage, advanced stage? It doesn't really matter.
Yeah, it's the same. Typically we see, that the vast majority present with early stage disease. Surgical resection can be highly effective. What we sort of let go of recently is this designation of type 1 versus type 2. Now, papillary renal cell carcinoma is really just given a broader designation. But before, when we had that term, we did see a lot of patients with the so-called type 1 disease, which was about 20% of cases of papillary that had a very, very indolent course, whereas type 2 was a lot more aggressive. But, I think the key tenet is that local aggressive therapy is the key when you have localized disease. I will say, and this is very controversial, you'll get different answers if you ask me, Tony, and others what to do and how to manage with adjuvant therapy. I tend to be a little dogmatic and I stay away from adjuvant treatment for papillary. They just weren't included in a lot of the pivotal trials.
Are there studies looking at adjuvant in papillary right now?
We've been having discussions about this at the cooperative group level because you'd really need that sort of gravitas to run one of these trials. But at this point in time, there's no ongoing studies looking at adjuvant treatment in the setting.
So right now, surgical resection and observation after that.
That's what I would emphasize, correct.
Advanced stage, what do we do?
So advanced stage disease is complicated. Again, what's made it a teeny bit easier is that we don't have these type 1 versus type 2 designations. One thing I'll emphasize is it's really, really important to do genomic profiling in all these patients. Believe it or not, we've come up with, although it's a bit of a needle in a haystack approach, some rare patients with ALK translocations. And as you might anticipate, these patients actually respond really well to drugs like alectinib or crizotinib. But for the most part, I would suggest that the mainstay of therapy tends to be either a TKI or a TKI plus IO. We don't really necessarily have a definitive standard as we do for clear cell. My personal feeling is that right now, perhaps the best data set that we have, and I'm a little bit biased, is a trial called PapMet, which, we published in the Lancet a couple of years ago. This was a SWOG study, so my shirt today is a little intentional. But it's a trial that compared sunitinib as a control arm to cabozantinib to two other putative MET inhibitors, crizotinib and savolitinib, and it showed that cabozantinib outperformed in terms of progression-free survival. So, sunitinib was really outperformed by cabo, ergo, I think it's probably, the go-to option. Having said that, this is randomized phase 2 data. We don't have an overall survival benefit in the study. Pedro Barata just published that in the JCO not too long ago. So, while I'm saying that cabozantinib is a standard, you will get pushback from insurance companies and payers just because we don't have good phase 3 data. We're also starting to get a lot of very compelling phase 2 data from single-arm studies, trials of cabo-nivo, trials of len-pembro. All of these, I would suggest, are acceptable options. But Chadi, I know this sounds like a cop-out, but I would suggest that this is a place where we really, really need our community oncologists to refer these patients to us for clinical trials because I think we're close, but we do have phase 3 trials that are underway to really help establish a standard for the disease. And until then, I'm basically just going to be giving advice to lean on these really sort of haphazard phase 2 trials.
So can I go back? You mentioned something about the ALK. Can you expound on that a little bit? So if you have you check if the ALK and then you treat with the ALK inhibitors?
Yeah, again, this is not something you're going to see commonly. If you look at the new World Health Organization designation of kidney cancer, you'll actually see a designation for ALK rearranged kidney cancer. And that's what we're kind of picking up with these tests in non-clear cell disease. So it's really just a couple of hundredths of a percentage point, I would imagine, of cases of renal cell carcinoma. And we actually did, sort of dig into this with our colleagues at Foundation Medicine. But what I would suggest is that, under the circumstances, even in this rare disease type, if you can pick up those patients, they can really have a transformative benefit from ALK inhibitors.
And in the absence of that, you did mention this controversy. You probably using cabozantinib and others are using other of these agents. Two questions. One, are there any characteristics, whether it is genomics or clinical or phenotype of a patient that would make you pick one regimen versus another? And is it now duotherapy or monotherapy for papillary advanced, or what are we doing?
So I'll tell you the clinical dilemma that I face. So at City of Hope right now, the trial that we have ongoing is called PAPMET-2. So again, it's a SWOG study, and this one's being led by Ben Mon at the University of Utah. So this trial compares cabozantinib to cabozantinib and atezolizumab. So it's basically asking the question, do we do a TKI or do we do a TKI with IO? Now, when I'm sitting in front of a patient, I think that's a perfectly acceptable trial design for the vast majority of patients with papillary kidney cancer that I see. The only exception to the rule is that patient who's really got rapidly progressing disease, who's very debilitated, where you might only get one shot on goal. And there, I might err on the side of going with a TKI plus IO. But in the vast majority of cases, to my satisfaction, we haven't really proven to the same extent as we have in clear cell that IO is a meaningful contributor in terms of upfront combination. So that's why I'm still a big believer in doing these trials.
So before I let you go, any new drugs are you on the lookout for? I know the ESMO meeting is coming up, and there's ASCO GU and ASCO. It's like we have a meeting every weekend, I think. But what are you looking for in the next 6 months or so in terms of new drugs, new targets, anything?
Great question. So, I've been running a study for the past several years with Chris Suarez, who's a terrific investigator in Barcelona. And this is an international study, 300-ish patients looking at a drug called zanzalintinib. So it has many of the same properties as cabozantinib, but a shorter half-life in my hands. And we've published some of this data. It seems to be a bit better tolerated. And there's activity beyond cabo, which is quite interesting. So we just, in terms of what's in public domain, we have projected that we'll finish a trial called Stellar 304 in Q2 of this year. And that study looks at zanzalintinib plus nivolumab versus sunitinib. This is a phase 3 trial, international effort. It includes papillary kidney cancer. It might be the one, Chadi, to really sort of set a standard for the disease. So I encourage folks to keep an eye out for that.
Thank you so much for visiting with us, Mondi. Really, it's very helpful. A quick review on what to do with papillary renal cell cancer. Dr. Monty Paul from the Sea of Hope, thank you so much.
Always a pleasure, Chadi. Have a great day.
Thank you for listening to this edition of the Healthcare Unfiltered Express. Until next time, take care.